Welcome to Transform. I'm Mohan Girdardas, the founder and CEO of LeanTaaS. Today I want to talk to you about transforming the operational performance of the health system using math and AI. Health systems, as you well know, are facing the perfect storm. All three ends are true. Reimbursement levels are going down. The demand for healthcare services are going up, particularly aggravated by recent cuts to Medicaid, as well as rural hospitals facing pressure and closing. And the staff shortages have only continued to exist. What this perfect storm does is create two pressures: the pressure on capacity and financial pressure. In the past, health systems could grow their way out of pressure by adding capacity, building more hospitals, building more ORs, adding more units. The combined effect of having the financial pressure as well makes it impossible to just grow capacity out. What capacity shortfalls tend to do is to cause gridlock. And we see this in health systems. It takes weeks, if not months, to get an appointment for a surgery or to see a specialist for the first time. Patients throughout their journey end up waiting. What this does is it creates adverse consequences on three fronts: the patient experience, the staff fulfillment, as well as the hospital economics. Gridlocks are a hard problem, and it takes sophisticated capacity management techniques to dig out of them. Let me make that come to life. When we think about rush hour on the freeway, that's a gridlock. That's an exact example of capacity shortfalls. And what happens is, as you approach rush hour, it doesn't become just a little bit worse. It becomes much worse. Specifically, think about a freeway outside of rush hour and think about the key metrics that matter: the commute time, how many people are impacted by an accident, how long it takes to clear an accident, and think of the same freeway in the middle of rush hour. Every metric is much, much worse. Not slightly worse, it's as much as 5,000 times worse. Now, here's the good news. It takes a few intelligent changes to drive an enormous impact. How do we know that? Think about what happens to the freeways at rush hour on a bank holiday. The commute times are half. Well, half the people are not bankers. 5% of the people are bankers, but they're the right 5%, the kind who work 8:30 to 5. When you get them off the freeway at rush hour, it makes life better for the other 95%. So that's the essence of optimized solutions. Find the bankers. Find the 5% of discharges that, if they were accelerated, would make the other 95% go better. The 5% of OR minutes, if moved from Dr. X to Dr. Y, would make surgery allocations go much better. It's a moving target for sure, but that's where math and AI comes in. So let me share three concepts. Concept one: healthcare operations is a network problem. It's a nodes and edges problem. What do I mean by that? Every service in healthcare operates somewhat autonomously like a node. Labs do their own thing, clinics do their own thing, ORs do their own thing. And the patient in their journey bounces through a series of nodes. Think of those as edges. Now, in a node and edge optimization problem, you have to optimize the nodes first before the edges. This is why Amazon makes its warehouses automated before it tries to do drone deliveries. This is why Cisco makes its routers faster before it tries to make the pipes fatter. Hospitals, unfortunately, have tried to solve with edges first. That's why they have case managers and coordinators who coordinate the coordinators. It is impossible to solve this problem edge first. Let me give you a practical example. This is the route map of Delta Airlines. They serve 200 airports in the US. The number of hubs they have is 9, just 9. Compared to 10 years ago, when Delta moved 160 million passengers a year, today they move 200 million passengers a year. That's 3 million extra passengers every single month. The number of flights hasn't really gone up. Delta had some 5,000 flights a day 10 years ago. They still have roughly 5,000 flights a day today. The planes aren't flying any faster. It's the same 737s that were flying 10 years ago. So what changed? Their hubs got better. Atlanta, Salt Lake City, New York JFK, LaGuardia can all process more passengers at a higher velocity. Their yields got better. They use sophisticated yield management to fill their planes better. As a consequence, they can see 3 million more passengers a month and make the transport happen. What's the analog for us in healthcare? The hubs are the key nodes: ORs, inpatient, oncology services, imaging. There's a collection of nodes where if we got those to move faster, it's like the hub airports. And utilization is like filling the planes better. Better OR utilization, faster LOS, and better bed census, bed utilization. All of those are the same metaphors that can be applied here. Concept two, in manufacturing, you can live with the supply and demand signals being slightly out of sync. If you're manufacturing something and you get an order for more things than you can make, you could just pull it from the shelf and ship it. In a service, you can't do that. Who are you going to pull from the shelf, the cardiologist or the patient? So the supply and demand has to match, not second for second, not even minute for minute, but in every 10, 15-minute windows, they have to match. In order to make supply and demand match, you have to understand them at a very, very detailed level of granularity. On the supply side, what are the facilities? What are the skills? What are the equipment? When will they show up? Are the right skills at the right time in the right location? On the demand, how many patients will need to be served? For what services? At what time? Will they be late? When we point this out to healthcare, the response is yes, but that's hard to do. And the operations go back to people calling patients and scheduling appointments, or surgeons faxing orders to the OR scheduler. Here's an example of someone who knows how to balance supply and demand dynamically at scale. Every minute of every day, on every street corner, in every major city of the world, Uber has to match the demand for a ride, which, by the way, nobody gives them more than a 10-minute heads up, with the supply that is made up of a car that they don't own and a driver who doesn't work for them, and they have to do it in 10 minutes. So they're not relying on fax machines and phone calls to make this happen. They have built demand models: time of day of week, seasonality, weather, traffic, sporting events. On the supply side, they know who drives where and when. They change driver incentives to bring the drivers out to work. They reposition drivers by text messages so they can go where the demand is. They do surge pricing to shape the demand curve. What this does is it makes supply and demand match minute for minute by predicting the demand, predicting the supply, nudging the demand, nudging the supply. That's exactly what each of our solutions does, managing the demand and the supply on both sides of it. Concept three is to optimize an edge, you have to anticipate the bottleneck and reduce it across an end-to-end flow. Doing process improvements on one step of a 10-step journey makes that one step faster, but it doesn't change the duration of the journey. So if you took a notion of how a patient starts by talking to the surgeon in their clinic, and then they go through a bunch of steps, and finally the surgery is completed, if you viewed that entire journey, anticipating where the bottlenecks will come and fixing them in advance is a very powerful concept. We all remember driving without a navigation system, either on a phone or built into the car. And when the traffic got bad, you just found out because you got stuck in it. And when you got stuck in it, you actually had no good idea of what an alternate route could be, unless you happen to know the area very well. Think about what we all take for granted now. Well before you get hit with the traffic jam, you're aware that it's brewing, and you've got alternate routes. In fact, you can plan your journey weeks in advance and know approximately how long it's going to take you with a fairly high degree of precision. That is what we aspire to get health systems anticipating bottlenecks and fixing bottlenecks before they happen. Concept four is this just does not solve with simply having AI and software thrown over the wall. It takes automation. Why? Because 20 or 30% of the time spent by your front line is on tasks that a seventh grader could do. Pull this number from the EHR, get this piece of data, cut and paste into an Excel spreadsheet, send a text message. These are things that could be automated. And if they are automated, the front line has the opportunity to work at the top of their license and do patient care, which is what they signed up to do, and the work goes better. And it takes change management, because getting people to do things slightly differently takes an effort, particularly in the beginning. If the new change results in people getting a better answer in an easy and intuitive way, then the change effort slowly declines over time. No one from Uber is sitting in my house bullying me into using Uber. It just is a better way for me to find transportation. And so the change management task, in some sense, has now become easier than it was at the beginning. So a quick introduction into how we think about our vision. Our vision is to deliver intelligent air traffic control capabilities to health systems. And as a mission, we've said, we want to help health systems enable their operational sophistication to catch up to their clinical brilliance. Every day in all of your health systems, true magic is happening. Genomics, precision medicine, proton beam therapy, robotic surgery. This is the stuff of science fiction. If someone had told you 10 years ago this would be happening every day, we wouldn't have believed them. Yet, operationally, we still have a long ways to go. And it's our mission to help health systems use the kinds of things we're talking about to catch up to the clinical brilliance. Our approach is to optimize the major assets, one at a time, individually, and then to link them together to improve patient flow across the system. This is exactly analogous to the hub and spoke model I was talking about. Along the way, our approach has got a lot of validation. KLAS 2 years ago created a new category called best in class in capacity management, a category that did not exist. And we have won it both years, and we're very proud of that. Across the country, about 1,200 hospitals use one or more of our solutions. They belong to 200 of the leading health systems in the country. And within the US, on an annual basis, we optimize 2 million stays, 4 million surgeries, and 8 million infusion treatments. So our footprint is large and growing. We invented this concept of applying the sophisticated thinking of yield management from airlines and logistics into healthcare. In 2013 is when we first invented it. In 2020, we wrote a book called Better Healthcare Through Math, and we'd be happy to share that with you. There are three solutions we have. Let me give you a minute on each one of them. Infusion centers was invented in July of 2013 at Stanford, when the guy who ran Stanford back then, he still runs Stanford Cancer right now, is an ex-GE guy, and he said, why is it that my infusion centers look like a train station in the middle of the day, meaning that the chairs are full, the waiting rooms are full, and nurses are scrambling, but it's empty morning and evening. And we applied the math that I've talked about and optimized it. That was one infusion center and 50 chairs. Today, 750 infusion centers, 16,000 chairs run IQ for infusion centers. UC Health in Colorado was the second customer of infusion and the first customer of operating rooms. That was in 2015, 2016, one hospital, 50 ORs. Today, 700 hospitals, nearly 6,000 ORs. Inpatient flow, 30,000 beds across 100 hospitals to optimize flow. Over the course of Transform, we're going to make announcements on new capabilities on each of these products. So what makes the LeanTaaS guarantee distinctive? I think it anchors on three pillars: the invention and the pace of innovation, the customer references, and what we call TaaS, transformation as a service. Let me make that come to life a little bit. As I said, IQ for infusion centers we invented in 2013, 2014. 2015, 2016, we invented IQ for operating rooms at UC Health, and 2018 was when we invented IQ for inpatient flow. Now, many of you saw in August of 2023, after 45 years of delivering EHRs, Epic announced capacity planning tools for the very first time at their UGM, August of 2023. And their capacity planning tools had three solutions: infusion centers, operating rooms, and inpatient flow. I'm sure it was a pure coincidence, but those are the three solutions they announced. Well, since then, 650 operating rooms on Epic, 3,000 infusion chairs on Epic, and 11,000 beds on Epic have signed up. Across our customer base of 200 health systems, approximately 60% are on Epic. So our solutions do work very well in an Epic setting. A word on TaaS. For each of our solutions, for each of our customers, we dedicate an expert team that stays with the customer for the life of the relationship. Stanford went live in 2013, 2014 with Infusion. Our team still talks to them every few weeks because the solution evolves, new ideas need to be incorporated, and that's the spirit of continuous innovation and partnership that we create. I want to turn it over now to Rami Karjian, who heads our IQ4 OR business, to walk you through what we're doing in the operating room arena.
Thank you, Mohan. Let me illustrate some of those concepts that Mohan went through in the context of the peri-op space. And in particular, today, I'm very excited to announce that we are consolidating the perioperative ecosystem in order to further drive that end-to-end optimization that Mohan described with an enhanced platform for our surgical clinics. So I'm going to go through and share with you examples of those concepts in both the OR and the surgical clinics. Starting first with the OR, we think about optimizing the OR in terms of optimizing rooms, staff, and the cases that flow through those. In particular, for rooms and staff, our platform helps balance supply and demand by helping predict the supply and then optimize demand against that. So a few examples of that is number one, for tactical use of OR time that is happening a few months before the surgery, we really focus on driving early release and reuse of available block time. That allows us to open the supply and then match the demand to it. In the same way, for more strategic use of OR block, we focus on optimizing that block allocation, creating supply by understanding where we can take block that is collectible and unused, and then unlocking demand by giving that block where it is most strategic for you, the health system, and where it is most likely to get used. And then from a staffing standpoint, we think about automating staff assignments by predicting the demand with a high degree of accuracy 2 or more weeks in advance, and then doing the best fit of the supply against that. So let me bring that alive with a few specific examples. First, on opening up supply of likely to be unused blocks. So on the left of the screen, what you're seeing is the calendar, which we're able to do with a 99% accuracy of predicting a month in advance how many blocks each day are likely to go unused. And the darker the color, the darker our confidence in the likely unuse of that block, from 90% for the light green, as I said, to all the way up to 99% confidence with the dark green. We are not only able to predict that by day, a month in advance, but get that down to a specific block owner, whether that's an individual surgeon or a service, and the confidence of that block going unused. That then allows us to nudge that particular service or surgeon saying, hey, we have a high degree of confidence this block is not going to be used. You can release it and we can put that back in the pool. And in that way, we're able to move, on average, the release of these blocks to 21 days before surgery, with some of the best health systems doing it earlier even still than that. So that's one example of opening up supply and using that optimization to create the capacity. Now, in terms of matching that supply to the demand where it's most needed, here's an example of where we're looking at both sides of the coin. On the left-hand side of your screen, you're seeing for a particular day, in this example, it's for Mondays, who is the block owner with the most collectible blocks that we can take away without necessarily affecting the number of surgeries that block owner is going to be able to do. So in this example, for Mondays, for cardiac surgery, there's 5 big collectible blocks a quarter that we can take without affecting the surgeries because they're going out unused. And then on the right-hand side, the 2 surgeons that are most likely to use that particular Monday block and how many of those slots should be allocated to them. Now, if you take exactly the same concept to staffing, with an 87% accuracy, we're able to predict 2 weeks in advance the actual case volume on a particular day, both by looking at what's already been scheduled, then of course by filling the gap on what is predicted for that day. We're able to then get that down to a by day, by hour prediction, which we can then use to anticipate what staffing need is required as compared to the staffing need that you have available. And we're able to do that for the circulator, the scrub, and the anesthesia resources. And that then creates a heat map of where there's over or more likely understaffing and where that is most pronounced. We're then further able to take that another step forward and automatically fit the best team, clinical nursing, as well as anesthesia, to the cases for that room for that day to meet the demand. So that's an example of that concept that Mohan was sharing about optimizing by balancing and predicting supply and demand. Now, I want to go back to consolidating this perioperative ecosystem and take those same concepts and share with you what we're doing now with an enhanced platform in the surgical clinic and how we're connecting that node of the surgical clinics into the hospital OR and the ASC OR. So first, just to baseline us a little bit on the world of the surgical clinic, which typically is a black box, particularly from the health system standpoint. There's a lot of cases that the hospital and the health system don't necessarily see that are lost due to the chaos that's happening within a distributed environment of the clinics every day. It can take weeks to get an initial appointment in the clinics. There's a lot of complexity the clinics have to go through with the prior auth, coordinating and scheduling the cases, making sure that the clearances are done, the patients are optimized, lab work is completed on time, and an enormous amount of patient education and engagement that the clinic is also driving. When those aren't done optimally, cases drop out and they're lost, they're canceled, or they're performed later. Our data would show that 35% of cases are lost and never make it through to the OR schedule. What we've also been able to find in the early application of our enhanced platform is that we're able to recover 72% of those cases. And this is making sure that surgeries don't go elsewhere, making sure they're getting scheduled, they're adequately prepared, the patient is optimized and has had the education. The other thing that we found is also the enormous complexity that's only getting worse by the day with coding and the financial errors that can be driven through coding. So here we're sharing some of the research that was done by Premier that the cost to fight denied claims for healthcare overall is just under $20 billion. That 5% of net patient revenue is actually lost due to unresolved denials. That in fact, 25% of all the denied claims are due to coding. And encouragingly, 86% of those coding related denials are potentially preventable. And so we've enhanced our surgical clinic platform to precisely deal with that problem. Now, to bring that to light, let's look at what that platform offers and how it can drive to solve the solutions of both missing cases and coding errors. There's 4 core components to where we've enhanced our surgical clinic platform. One is helping the surgeon and the surgeon's team build that case so that it's not reliant on tribal knowledge and post-its to build the initial case. By building the case right, we're also able to solve the problem upstream at its root and address a lot of the issues that then cause problems downstream in the OR. We're also creating case visibility to the status of the case, the next step, any issues to that case that both the clinic and the OR team can see together. We've added patient engagement tools to the platform where we're able to do text messaging with the patient, where we're able to send emails to the patient, even send emails to the patient's other providers, their cardiologists, their PCP, to aid in the optimization and the clearance process. And then bringing all of that together with advanced analytics on what the state of managing that pipeline of cases through to scheduling looks like by clinic, by surgeon, by team, by specialty, to highlight where additional focus would help. If I take just one of those, which is the case builder, and give you an example of this platform that's now available given the enhancements that we've made. Just for fun, let's take a particular case for a posterior lumbar interbody fusion, also known as a PLIF, and what the notes that a surgeon may write in doing a patient consult to indicate that that patient requires surgery. So here's an example of that for a 57-year-old male who's going through a case. Now, let's dissect that for the surgeon and their team around what's required to accurately code this case. First, the specific region, whether it's cervical, thoracic, or lumbar, needs to be identified because that's going to change the codes. The specific technique that the surgeon is doing to do this fusion is going to need to get dissected to understand the coding behind it. The decompression decision that the surgeon will use, and also whether this is a professional versus a facility code requirement can change it, so can the specific ICD-10 that's driving it. Now, we're asking the surgeons and their teams to keep up with all of these decisions, changing structures on how this is done to get the coding right. And admittedly, this is a very complex spine example, but this is why there's so much complexity and why hospitals spend so much cleaning up a lot of this coding on the back end, and why the surgical clinics themselves are so frustrated about trying to get payment timely for these surgeries given this type of complexity. So in our enhanced platform, what you see, this is a screenshot from the beginning of building a case. On the right-hand side, you see where that surgeon would have picked from their pick list of how they normally do these spinal cases, and it would have pre-populated everything that you see here, including where that green arrow just popped up, what CPTs are specifically going to get billed for the standard case the way this surgeon does them. And then as that surgeon goes in and changes details about the site, those CPT codes will change as well. So we've taken something that has an enormous amount of complexity, frustration, errors, and rework, and really solved it at the source by helping the surgeon navigate that in a way that's driven by AI and ML, so that fundamentally there's less issues with a case getting coded properly, getting the reimbursement, and getting that reimbursement timely. So then, now back to our ecosystem. Those are some examples of how this applies in the clinic and in the OR. When we pull all of that together and optimize both the nodes of the clinic, the OR, and the edges that connect all of them together, life becomes very different for the patient, for the OR team, and for the surgical team overall. So 6 months in advance, we're already seeing that we're able to proactively create and fill operating time and open up access for the patients and for surgeons who want to care for their patients. 60 days in advance, we're understanding what is the latent demand that still needs to be filled, and we're matching it to where supply is available. We're also making sure that we're coordinating the site of care, clinical aspects of the cases, payer, and the prior auth process early on when the patient is first indicated for surgery. Now we get to a month before surgery, we're able to predict with 87% or better accuracy the case volume, the room the case should go in, the equipment that's going to be required, the utilization of the block, the rooms, and the equipment, so that now that OR perioperative team can start to really optimize based on those predictions. We're also helping the team focus on optimizing the highest complexity patients early on to reduce the cancellations. And if a cancellation is required, have it happen earlier in the process so that the patient and the team can reschedule easier and so that that slot is more likely to get filled. 2 weeks in advance, then, we're matching the predicted case volume with the forecasted staff. We're doing a best fit of the experience and the skills of that staff to individual OR rooms. And we're avoiding any additional surprises by having automated engagement that's AI driven with the patient. All of that so that on the day of surgery, we end up having the right team on an optimized patient, doing the surgery in the right place for the team and the patient with the right equipment that they need to be successful. And that really helps tame the chaos of the OR and lead to better outcomes for the patient, the system, and the surgical team. Now, there are no shortcuts to operational excellence. As Mohan said, we've been at this for more than a decade, and the techniques and the platform that we've developed has been battle tested over a 10-year period. With 100 health systems just in the OR, 550 hospitals live on our platform, 12,000 surgeons, 5,600 ORs, all of that supported by our team of 130 full-time dedicated perioperative experts that are working with our customers to achieve results that allow them to continue to improve their perioperative experience. So what does that look like? From a hospital perspective, we see 1 or 2 more cases per OR per month, a 25% decrease in premium pay because of the way we're able to do staffing, increased utilization of robots that are brought on board, and as a result, primetime utilization up on an average of 4%. For a surgical clinic, it's a 5 to 10% increase in the cases that clinic is doing because they're not losing as many cases, $250,000 of increased revenue per surgeon, and a 10% decrease in coding errors from the enhancements to the platform that we've made in the surgical clinics. I'm really excited for you to hear more about this from the colleagues that are following later today. We've got our colleagues from Rush sharing their experience doing some of that block optimization. We've got our colleagues from Northwell sharing how they're thinking about staffing anesthesia challenges in particular. And Cone Health, Dr. Sui will be sharing how they brought some real-time visibility to better manage the OR. So we've got an exciting day for you today with our Transform. Hope you enjoy it, and please reach out to us as we can help you in your journey transforming your perioperative operations.